Okay, hi everyone. I think it's time that we start what I think will be a very interesting session about the effects of mental health on the patients living with diabetes. My name is Louise Granlund, and I'm from the Swedish Diabetes Association.
Hi, and I'm Loretta Vilikide. I'm from Lancaster University in the UK. I'm a diabetes physician researching in diabetic complications and the ways that people with diabetes adapt to complications such as neuropathy and foot ulceration. And I'm exploring concepts such as depression, quality of life, adherence, and acceptance of digital technologies.
And just our thought is that we will save up all questions for the end. So you can also ask questions in the app and then ask questions to all the speakers at the end of the session. And our first speaker is Nasser Al-Tublani. He is currently pursuing his master's in clinical psychology and is also working with young people in child and adolescent mental health services. So please welcome to the stage.
Right. Thank you for the introduction. My name is Nasser. I'm not going to stand behind the podium because I'm a bit more comfortable walking around. So today I'm going to talk about the effects of diabetes on mental health and specifically focus on what diabetes is like beyond the clinic and how it exists beyond the clinic as well. So at this point, I have no conflicts of interest to declare for this presentation. So just a bit of introduction about myself. I've been living with diabetes for around 23 years now, and I've been involved in diabetes advocacy, volunteerism for quite some time as well. My volunteerism and advocacy specifically started when I was having conversations with children and their parents at the time of their diagnosis. And I think at that point, I picked up a lot of interest about how people cope with diabetes and how people generate meaning. And I think it's been kind of a bit of a journey from there. I picked up an interest in meaning making. I picked up an interest in coping mechanisms. And with that also came my study in psychology and then pursuing clinical psychology as well. Currently, I'm a clinical psychologist working under supervision at a CAMS center. So when I say CAMS, it's a child and adolescent mental health services center. I also conduct research on diabetes distress, self-management behaviors, and cultural competency. So I'll try to kind of bring these things together when I talk about the ideas of mental health or the concepts of mental health today. So with a lot of my cases, I see individuals diagnosed with diabetes. With a lot of my volunteerism, especially conducting peer support sessions, talks, workshops, I see a lot of individuals who report and present with a lot of challenges associated with mental health and diabetes. So I'm just gonna walk you through how I try to conceptualize how the struggles with diabetes kind of emerge and how they're dealt with, right? So this is a pseudonym. I met Kareem at the CAMS clinic. And this clinical vignette, I'm gonna walk us through it and I'm gonna try to illustrate it throughout the presentation. So when Kareem presented, Kareem was 17, and I saw him for around 12 to 15 sessions. And when he presented to the clinic, he presented with symptoms of loneliness, isolation. There was a lot of depressive symptoms as well, including suicidal ideation. There were also symptoms of low appetite, very consistent low mood. There was also non-compliance with diabetes management. He wouldn't take his insulin. He wouldn't check his blood sugar, and he consistently reported feeling overwhelmed with the demands of diabetes. There are different ways that we conceptualize the distress associated with diabetes management in the psychological field. Okay, so in merging diabetes and psychology, what the golden standard currently is the concept called diabetes distress. And it is diabetes specific and condition linked. So it's not a psychiatric condition, right? It's not a psychiatric diagnosis. So everyone has diabetes distress and it exists within a spectrum and so on. And it is a response to the daily demands of management. Then there are concepts such as diabetes burnout, anxiety, depression, which are typically framed as outcomes, right? They're outcomes of the toll, the psychological toll linked with diabetes management. Here, with both approaches, there are a couple of inherent assumptions, and this is not a value judgment, this is a very descriptive analysis of this. There are inherent assumptions within these methodologies and conceptualizations. One of which is there is an implied linearity. So it's a linear process, right? There is difficulty from diabetes, insulin demands, hypoglycemia, stigma, and so on, and this leads to distress. It's a very linear and predictable trajectory. And then it's also isolates diabetes as a main source of distress. Whether that's true or not, regardless, we're going to get into that in a bit, but inherently, diabetes is distressful. That's what it assumes. It also assumes universality. So regardless of your personal history, you're going to have distress, and it's going to manifest in these ways, right? Which has a couple of limitations that we're going to get into in a bit. So in sitting with Karim, we did a lot of explorations about what happened to Karim. What were his experiences like? And in talking to him, we realized there are a couple of factors that are potentially contributing to his current presentation. One of which is Karim had an overprotective and an anxious mother. And he kind of internalized this anxiety and got the idea that the world is not necessarily a very safe place. It's not a very predictable place. His father was absent. He was very unreliable. So also giving ideas about abandonment, potentially, unreliability, which we also explored in Lens. He was forced to take care of his younger siblings. So again, parents being unreliable, because again, adults are supposed to take care of us, not we take care of them, and so on. And he was diagnosed with type 1 diabetes at the age of 6. So we see there are a couple of factors happening simultaneously with diabetes, right? It's not all of these things were happening as background noise, and then diabetes happened, and then it led to that distress, right? It was happening almost simultaneously. Psychologists like complicated maps, but it looks complicated, but it's not, right? It's quite straightforward. So there are what we call vulnerability factors, right? And these vulnerability factors are critical incidents from the person's childhood, which lead to things that we call beliefs or internalized systems that we kind of perceive the world through, right? So the beliefs in whatever is between quotation are quotes that the patient has actually said, right? And we use a couple of techniques to reach there. So Karim mentioned quite frequently that I am fragile and worthless. This feeling of fragility, right? There is this feeling of fragility, worthlessness. Others are untrustworthy. That's how he sees adults and others. Life is unstable and unpredictable. And it's quite interesting for me to see how all of them interact together, or the vulnerability factors kind of interact together to lead to this belief system. So if we look at diabetes alone, it might not lead to feelings of worthlessness. It might give us the feeling of fragility, but it's the combination between the overprotective mother and diabetes that led to that feeling of fragility. About others being unreliable, because diabetes needs this consistent self-reliance, but also the father was absent, so there is a very inherent and a very dynamic interaction between all of these factors. So he kind of made rules, he internalized rules about how to deal with the world. And one of them was, I must keep tight control, or things will kind of not, or I will not be safe, or things will fall apart, which is something that a lot of individuals living with diabetes also internalize. But it's also interesting the nuances that are created by the interaction. And then he presented to the clinic after not getting accepted in his aspired university and being broken up with his partner, right? And it's quite interesting talking to him about his ideas of success and how success is also conceptualized as a very rigid framework. I have to do A, B, and C, or else I'm not successful. And this led to the problem. So we can see how this might be a different conceptualization and potentially a more nuanced, a more realistic conceptualization when we look at the current distress as all of these things instead of just diabetes related. So what gets missed in the prevalent model, so when I talk about the prevalent models, I'm talking about diabetes distress as the golden standard, but I'm also talking about the other variables I spoke about in the beginning. It kind of defies logic that current conceptualizations in diabetes and psychology compartmentalize diabetes as affecting one aspect of mental health, right? So it only affects diabetes distress. It only affects your hypoglycemia distress. It only affects your management distress. When in reality, there is a lot of interaction happening there. And being a person living with type 1 diabetes for almost 20 years now, and talking to my colleagues about it and having a lot of conversations since a very young age also, I've also come to realize that this condition especially interacts with every dimension of the individual psychological landscape. It's not something that takes a pause or something that exists in a different compartment of living, right? So research comes in and tends to reinforce this by isolating diabetes and putting it in very measurable categories, right? So there is the hypoglycemia distress. There are 7 subcategories on how you must be feeling this stress, right? So a prime example of this is Kareem complained of this and presented with this constant sense of being monitored. He felt like, he was like, Nasser, I have this feeling that I'm always kind of feeling calculated, feeling monitored, feeling watched, right? He had the sense. And this potentially came from diabetes, but came from a very overprotective and a helicoptery mother as well, right? And not only that, but it affected the way he views relationships. A lot of his relationship problems came from that feeling of him always being hypervigilant. It affected his views on success, the rigidity, interpretation of life events, about others' reliance and so on, about his sense of fragility, about emotional expression, weakness, and so on. So it's important to note at this point that diabetes not only affects the current presentation, but it also affects the etiology, as in where the problem comes from. So there is a very inherent dynamic and a very inherent interaction that happens between diabetes and all the other critical life incidents. And at this point, I do not mean to catastrophize diabetes as the bigger evil. No, it's just understanding that there is a very inherent interaction happening between all of these factors. So why does it matter? Why does it matter talking about all of these things? One of the things that I think a huge limitation of this is I think it risks oversimplifying the lived experience, right? It captures a very specific and a very reductionist aspect of lived experience. In my work as a CAMS practitioner, I've rarely had kids present with diabetes. Parents come and say, my kid's struggling with diabetes and so on. But when I meet with the child, they talk about things like grief. They talk about things like loss of control. They talk about things like emotional expression. They talk about things like anger. They talk about things like choice, right? But when these kids like Kareem or other kids I see, kids we talk about in research, when they express frustration, aggression, suicidal ideation, burnout, and so on, they're either medicalized through symptoms, they have depression, they have anxiety, and we need to talk about it, right? This is the idea. Or they're giving coping strategies, right? Breathe through your distress. Find a way to dissociate or go to your nice place or happy place or whatever, right? And there is this idea of like have a daily reward and so on. So we can see how this does not necessarily capture the nuances created by the interaction of both the etiology and the presentation. So obviously there is an overemphasis on pathology, on symptom management. So fix the symptoms, go home, another patient comes, fix the symptoms, go home, and so on. So we need to move beyond these models of categorization and start understanding and trying to capture the nuances captured by lived interaction. Another thing that these models miss is the interaction with the structural, right, and the systemic factors. So a lot of these conceptualizations, a lot of these treatments, they disregard the cultural, economic, political, and social factors that actually shape the experience of diabetes. There is an overemphasis on individual responsibility. But let's not look at the economic. And here I'm specifically talking about psychological research. I know other areas of research that you guys might belong to. There's different ways of conceptualization. But in diabetes, specifically diabetes distress, there is a very interesting focus on individual responsibility. But you have the distress, you have to learn how to cope. do yoga, do meditation, try to find people to help you, and go to therapy, and things will be solved. So there is an overemphasis on what I need to do as a diabetic, what I need to do. And it ignores systemic factors in this process. Systemic factors such as food accessibility. It ignores factors such as financial restraints, such as how much access do I have to technology, to medication. So it's important to note at this point also that diabetes is embedded within these social structures, right? Diabetes does not exist independently. It does not exist within a vacuum. It exists within the social structures of race, of gender, of disability, of class. And these things do not exist in fantasy, right? So when I talk about this in my talks and my research, a lot of the things I get, that's why does this matter? It exists in fantasy, and that's how the psychological community likes to conceptualize things that exist in anxiety, that they exist in fantasy, they're imagined, but they're not. They're tied very well to the realities that the patient experiences. I was giving a talk recently, and was on coping mechanisms, and it's also always interesting hearing people talk about their experiences with diabetes and stress. And in the conversation with him, when it comes to the lack of insulin in his specific locale or his country, he spoke about how a lot of the time it leads people to ration doses, right? So he says a lot of us take insulin once every 2-3 days because we don't have enough insulin. We eat barely. We resort to traditional medicine, and this is in psychological research sometimes looks at education. We need to educate people, but a lot of individuals don't necessarily have have access to all of these things, but it's also framed in research in that way. They guess blood sugar levels by feeling, they borrow money to buy medication, and there is evidence of high mortality rates in the locale as well. So you either buy the medication or you die. It's a very specific formula, right? There is a lot of linearity there, potentially. And again, I really want to stress on how this is not imagined anxiety. It's not like you have fear of you're going to be hypoglycemic a lot of the time, and that fear is exaggerated. When people go to therapy, a lot of the times this is what happens, that you need to learn how to cope. You need to learn how to cope with the thought, with the feeling. But again, this is quite different than that. It is not imagined anxiety. I'm running out of time. Okay. And this is quite a powerful reminder that psychological care cannot be separated from the structures that it exists in. And breathing through your distress might be a bit of a long shot as well, because we're talking about quite a different thing. A lot of the times I get a very interesting questions whenever I give talks about mental health. And they say, Nasser, do you think that every diabetic should go to therapy? And it gets more complicated the more I get asked this question. I don't get more clarity on this question. And understanding these factors, understanding what my colleague from the Global South said, understanding all these interactions that we spoke about, we can understand why medical access is incomplete and sometimes almost irrelevant. Irrelevant to breathe, irrelevant to go to your happy place, irrelevant to learn how to cope. Understanding and having a place for emotion, yes. But without securing medical access, it kind of feels irrelevant. If someone needs their medication for survival, you can't go, you learn to know how to cope and do the butterfly hug and so on, right? So mental health support in therapy, I'm talking specifically, therapists must be structurally competent, right? Not just clinically responsive, not just have a place for emotion, but also have to have an understanding of structural competence. And what I specifically mean with that is not just ask, what are you feeling, but also ask, what are you navigating? What are you navigating? What types of access are you navigating? What structural difficulties, what class, what social systems are you navigating in the process of getting or presenting with this distress? They have to ensure basic health needs are met first before commencing psychological work, or do it simultaneously. They need to link individuals to resources and involve community, so the work does not get compartmentalized into, this is what happens in the clinic and this is what happens in the street, right? There has to be something that captures the interactions that happen in lived experience and which are inherent and a fundamental part of it. So it's quite important for us to start rethinking care models that are grounded in patients' lived experiences and structural experiences as well. So combining lived and structural experiences. So I'm usually not great with time, so this is amazing that it's a minute left. Yeah. So it's quite important for us to understand that lived experience is not an add-on, right? It's not something that exists independently from research. It's not something that exists independently from the clinic. It's the ground which care must be built on, and diabetes is not a compartmentalized stressor. It does not make sense that we look at it as a compartmentalized stressor where it exists very simultaneously with all the other factors. The isolation of distress from context and structures is a huge limitation in current psychological research. Mental health support that stops at coping and how you need to cope has a lot of limitations, right, that we spoke about earlier. Finally, what my recommendation here and what I argue here is psychological care must be structurally competent. And we need to understand that structures are not just background noise. Structure, context, social systems, they're not just background noise. They're an inherent part of lived experience with diabetes. They're an inherent part of distress. We need to understand how to link individuals to communities and to real material resources instead of focusing on a very individualized aspect of therapy. This is what I have to say today. Thank you.
Thank you very much, Nasser, for a very interesting introduction to this topic. And just as a reminder again that we hopefully will have time to do questions to all the speakers at the end. But for now, we have to move on to the next speaker, Amanda Rydén. She is the president of Young Diabetes Sweden, which is the Swedish Diabetes Association's youth initiative. And you have worked a lot with these issues of mental health in young people and advocated a lot that there's a need for better psychosocial support. So welcome to the stage, Amanda.
Oh, try? Yes. Hope you hear me. Hello, everyone. My name is Amanda, and as Louise said, I'm the president of Young Diabetes Sweden, which is a part of the Swedish Diabetes Association that works for the people in the ages 15 to 30 years old. And today I'm here to talk about the burden of living with diabetes on mental health. And I have no conflicts of interest to declare. So a little about me. I'm soon to be 24 years old, and I've been living with type 1 diabetes since 2018. I live in Lund in southern Sweden, where I study law, and I live here with my boyfriend and my assistant's dog, who I really miss very much when I'm here. I've been involved in the Swedish Diabetes Association since 2018. I started as a leader for camps for children with diabetes, and soon after that I became a board member at my local association. And I've been in Young Diabetes since 2021, and I've been the president since 2022. So I will start this presentation by trying to answer the question, what are the reasons behind poor mental health in especially young people with diabetes? And I will start to show you some statistics. Young Diabetes Sweden did a survey on this subject in the spring 2024. We knew about the problem with the diabetes and bad mental health, and we also know that a lot of young people, even if they have diabetes or not, are struggling with mental health. But we wanted to do a survey on this to see what this really is. So we see in the results that survey is about says that nearly 2 out of 3 young people experience that their mental well-being is negatively affected by diabetes to a greater or less extent. Nearly 2/3 worry to a great extent or very great extent about how diabetes will affect their health in the future. Among women, 71% say that they think about or deal with their diabetes at least once an hour. 1 in 3 in the same group says that they do it several times an hour. Among men, 54% say that they think about or deal with their diabetes at least once an hour. 52% of women say that they need psychosocial support, while the same proportion among men is 39%. So the Swedish Diabetes Association has also done a survey on this subject where all the age groups are represented. And the results we see is that over half of the people in the survey state that their healthcare providers only to a small extent or not at all pay attention to the need of psychosocial support that may arise in life with diabetes. 4 out of 10 state that they either have or have had a need for psychosocial support. 45% of people with type 2 diabetes responded that their healthcare providers do not pay attention to the need of psychosocial support at all, which is 70 percentage points more than among people with type 1 diabetes. And 73% of people with type 2 diabetes in need of psychosocial support state that they have not received the help they need from healthcare, compared to 53% among people with type 1 diabetes. In a global perspective, we know from EAAC that between 20 and 40% of individuals with type 1 diabetes have psychosocial problems linked to their diabetes. And a global survey from the International Diabetes Federation state that 77% of people living with diabetes have experienced anxiety, depression, or another mental health condition because of their diabetes. The fear of developing complications was the most common factor impacting mental well-being. Other factors include daily diabetes management, stigma and discrimination, and fear of needles. The survey also highlighted a clear call for better support, with 3 in 4 people living with diabetes seeking increased support for their emotion and mental well-being from the healthcare providers. So, to summarize this, we see that the problem of diabetes and mental health exists through the world at all ages and all different types of diabetes. Why? You live with diabetes 24/7 and you can't get any rest. Every day you have to face prejudice and ignorance. You worry about not being able to afford insulin or diabetes aids if you live in a country where this isn't free. You worry about how your blood sugar levels today will affect you in the future. You might feel alone, you might feel that you don't been seen or heard, and your family members worries about you, which makes you feel a burden to your loved ones. So over to my story. I got diagnosed in a time when my life was very hectic. Besides school, I have activities almost every day. So when I got my diabetes, I had to stop with all this because I had to learn how to live with my diabetes. So at first my diabetes forced me to slow down. And I thought that I would take this time to think about what will I do in life and what of all these activities should I continue with. I continued with all, and now I also have diabetes with all this hectic life. I also had problems sleeping. A nurse told me when I got diagnosed that it's important for people with diabetes to sleep well. In my head, I thought that meant I need to sleep 8 hours a night, or otherwise my blood sugar will go crazy next day. So the only thing I could think about when I was trying to sleep was, in 10 minutes I need to sleep to get 8 hours of sleep. And now I have to sleep in 5 minutes, or otherwise I will not get 8 hours of sleep. And when that's the only thing you think about, you cannot fall asleep. Thankfully, I got over this problem when I realized that I can handle a day where I haven't slept 8 hours, even if it's good to aim for everyone to have a really good sleep. My diabetes has sadly also increased my need of control, which is something that is still ongoing. And I think it is because you have to control your blood sugar, and that you also want to have control over your life in every part, because if your life is more controlled, your diabetes is also easier to control. In the beginning, I was alone, and I thought that was what I wanted. I didn't want to speak with any other person that had diabetes, and I thought that I'm good on my own. So it was a coincidence that I talked to another person that had diabetes. We met at something not diabetes related, and just to tell him that I had a low blood sugar and he knew exactly how that felt was such a relief. So I understood that this is what I need to do. I need to meet other people that has diabetes. And that's why I'm standing here today, because that made me want to tell other people with diabetes that you need to talk to other persons in the same situation. Moving forward, I will also, now that we know that people with diabetes struggle with mental health, we will look into what those close to a person with diabetes can do to provide meaningful support. And I think it's important to ask what help they want, not if they want help, because if you just ask, do you want help? It's easier to say no. But if you ask what help they want, you have to think twice, and maybe you can support them with something. Ask how they are, and then listen to the answer. Be careful asking about blood sugar levels and how monitoring the diabetes is going, because this can be perceived as offensive. And of course, advice on joining a diabetes association and or talk with other people with diabetes. Just as I said, it's so important to talk to other people in other situations, and this can be a lot of help. I will also look into what the healthcare professionals can do to provide meaningful support. And in Young Diabetes Sweden, we have seen that it's mainly 3 things that we want that we think would help people with diabetes, and we think that this is the same for all over the world in some way. So we want that all clinics should have diabetes teams with the skills that people with diabetes need. This includes psychologists, counselors, or equivalent skills. We want that special efforts are implemented to facilitate the transition between child and adult care in the diabetes area, and national guidelines for improving the transition process are an important first step. And we want that national measurable values for the psychosocial health of people with diabetes are introduced so that it's possible to follow up on developments in the area on time. But the most important things that we always say is ask the question, how are you? Because if we shift from just focusing on the blood sugar levels to see how the person really are dealing with the diabetes and how they are feeling, we think we will take a good step on the way. We know that people with really good blood sugars have to put in so much work that it will impact your mental well-being. And we also know that people with bad blood sugars might also have sort of anxiety and bad mental health. So if we focus on the mental health problem, we hopefully also get better blood sugar levels. So this question is a big step in the right way. Thank you.
Our next speaker is Professor Catherine Bernard Kelly. Is she here? Professor Kelly? Right, so hopefully that Dr. Kelly will join us later on, because I think that her slides are here. But then we'll move to our final speaker, is Lucia Fet. She here?
Oh,
But no, that was Lucia. That's not. Yeah, but oh, okay. Well,
then let's do some questions while we wait for one of the two speakers to show up.
two of the two speakers.
Yes. Do we have any questions for either Amanda or Nasser? Please, you can come up to the microphones that are in the middle of the row. And can I ask then Amanda and Nasser to please come up as well so we can...
It's okay.
Oh, no. Now let's do a question in between and then we let you up. Yeah, okay. Please go ahead.
Okay, my name is Margot. I run the National Diabetes Organization in South Africa. We were established in 1969. We have been doing outreach to children and young people and parents with children with type 1 for 50 years. So we realized very early on there were no resources, there was no literature. In those days we didn't have Google or internet or Facebook or TikTok. But we had passion. And so, you know, I'm really making comments, not so much as questions, but I will ask a question of everybody here. So we know the challenges that children and young people and even young adults go through, because these are different stages in life, and you go through different periods, ups and downs. Everybody has that challenge during their life with diabetes and their journey. You know, the great increase in diabetes since I started with the organization has been horrific. And from Africa, we beat drums. And I am beating my drum, and I have been beating my drum for a long time. What I would like to see is that if physicians treating diabetes, whether they are endocrinologists, diabetologists, whatever you want to call them, if they cannot provide education around diabetes, whether it's type 1 or type 2, if they cannot provide support, then they should be obligated, it should be mandatory that they refer to an organization or resources where those people, those patients can find support and help. And really, that is what I'm beating my drum about, and I've been doing it for a long time, and I'm so pleased now that we're talking about education. Goodness me, how long has it you know, how long have we needed? That has been the missing link since the beginning of diabetes. We've had, you know, insulin, we've had technology increase, we've had treatments, we've got, you know, all these things. But where is the education and support for those patients? Because that is crucial. We have had children and teenagers who were suicidal when they were diagnosed, and the pressure of living with diabetes has been so much they've said, I don't want to live anymore. It's just too much. It's overwhelming. You know, my life is over. And if somebody, whether the doctor, the parents, or somebody would refer them to a patients' organization that does children's camps, outreach to young people. We had one 18-year-old who was suicidal. Her family contacted me, and I said, just persuade her, just say, give it one more chance, come to one of our camps. Just give it one more chance, one more thing. That young lady came to a camp. Before that, she had been hospitalized about 6 or 8 times after her diagnosis. After camp, I heard about 8 months later from her family. They said it was like a total change. her positive attitude towards diabetes. One hospitalization in the year following. Her mental and emotional stability was restored, and she was ready to face the future with the journey with diabetes. And that's what organizations like ours do. We hold your hand from when you were diagnosed until your old age. We have specific programs for children, young people, and we are very fortunate where I am based in Cape Town. We have a psychologist who has type 1. He's had it since he was a child. Isn't that the ideal solution? Because he comes to our camps. Any problems that I experience from parents, he's there. He always answers my calls, even when he's busy. And I say to him, we need your help. And he does long distance. He will do telephone conversations, WhatsApp consultations. He reaches out and he comes to camps. And, you know, it's amazing when the children arrive, they are doing here and who these people are. And, you know, I'm really nervous.
Yeah.
And then he comes along and he's got a ball. Throws it. And he asks them a question. They sort of hesitantly answer. Then they throw the ball back. Then he throws it. And he says, do you want to say something? And in that way he draws children out. They start to talk amongst themselves. There are so many methods to help with the psychosocial mental health, children and young people. And from diagnosis, I just wish this would happen. Try and advocate that it is important, it is vital for the health of our people with diabetes, wherever we are in the world, that you link hands with the organizations in your country that help patients in whatever way they do. Because that is what has been lacking. There's a disconnect between treating medically patients, diabetes, helping other patients, introducing other patients. You were just talking about how important that is to meet another person with, you know, when I first started very many years ago with diabetes, yes.
Amanda, do you have any comment to this as well? You have worked a little bit with this, trying to outreach to the healthcare providers as well.
It's just a big that I agree agree with you, and we are trying to reach out to the hospitals with the member folders, for example. But in Sweden, it is also not the state that is in controlling of the hospitals. So every hospital region, if that's the that's the word in English, they do the decisions by themselves. So it's in some hospitals, it's always no to these member folders. So yeah, that's a hard part.
So my wish and my prayer is that we will convince the physicians, endocrinologists, GPs, anybody, whether in the hospital arena or whether they are in private practice or public practice, that they refer patients.
Yeah, absolutely. Please. Thank you very much for this comment.
I just wanted to double check if Professor Bernard Kelly, maybe she's in the audience now, our third speaker. No, okay. So we'll ask our final speaker, last but not least, Lucia Feito Alonka. She has type 1 diabetes for 33 years and serves as commissioner for the Lancet Global Health Commission on People-Centered Care for Universal Health Coverage. She balances her lived experience and her legal expertise in patient rights to promote people-centered care worldwide, including International Diabetes Federation, and also she, as the lived experience lead on the executive committee of psychosocial aspects of diabetes study group, she contributes to European Diabetes Association. Please, Lucia.
Hello, everyone. It's very nice to be here. I'm Lucia Feito Ayonca, and I have been living with type 1 diabetes for already 33 years. I wear many hats, but the hat that I wear today for this session is the hat of the lived experience lead for the psychosocial aspects of diabetes study group. When it comes to diabetes, it's not just biology and blood glucose levels, not at all. There's a very important psychological and emotional component in managing our condition. And I want to talk about that. And I want to invite you all to tackle diabetes stigma together, something that is really pervasive. It's really bad for us people living with diabetes. So I have no conflicts of interest to disclose. And, well, some acknowledgements first. First, I acknowledge all of you here present living with diabetes. Please stand up. Thank you for being here. And thank you to Professor, you can see it, and thank you to Professor James Spade for these slides that I have available for myself and have been given freely to any member of the community who wants to convey this message about the importance of ending and tackling, acknowledging diabetes stigma, that it exists and that is harming us. So an outline for the session. First, we will give a brief introduction on stigma. Then I will be speaking about the pledge and the international consensus. And finally, I will let you know what's next. It's something very exciting. So, but you have to wait until the end to get to know that. So, let's take a moment to think and reflect. What's the first thing that comes to mind when you think about diabetes? We all hold biases, and acknowledging them is really essential. It's the first step in order to see that something is happening. Generally, diabetes is associated to bigger bodies and healthy lifestyle habits, but it's not always the cause of developing diabetes. So this can lead to many misunderstandings, myths, and concepts that hurt people and affect their health outcomes. Diabetes has certainly an image problem, and we know that the blaming and shaming campaigns do not work well. When we see in the media this characterization of diabetes, we get scared. We are not getting better health results. It's good to be informed, yes, but is this the right way to convey a message? Is this helping us? Are we addressing diabetes as we should? What is diabetes? There are multiple types of diabetes. It's one of them with its own complex causes. And all types of diabetes are serious, require daily self-management, and are subject to stigma and discrimination. Yes, yes, this is terrible. All types of diabetes. It's impactful. And in this slide, the numbers were not updated yet. We know now that 589 million adults living with diabetes are suffering from stigma today. Not suffering, living, because stigma is also really connected to language. When we create stigma, when we internalize stigma, it's so interconnected to language, how we speak. We have to choose our words carefully. The connection is undeniable. I'm a person living with diabetes. I'm not diabetic, Even if some people don't mind being called diabetic, it's important to address that the person is still a person, not just a disease or a health condition. So the pledge. I don't know if you have already signed it, but if you haven't, please do it now. Let's go to enddiabetesstigma.org. And you will see there that there are some things that we can do, whether we are an organization or an individual, to change things. And we pledge to contribute proactively to bring an end to diabetes stigma and discrimination by respecting people with all types of diabetes, recognizing diabetes stigma exists and has harmful impact. 3, acknowledging and challenging our own prejudices about people living with diabetes, because sometimes it's inside ourselves, even inside people living with diabetes, we internalize what we have heard in society. Using accurate, respectful, inclusive, non-judgmental, and strength-based language. What I said about language matters. Messaging and imaginary when communicating with or about people living with diabetes. Avoiding and challenging fear-based messaging and imaginary. Condemning discrimination due to diabetes and advocating for equal treatment and support for people with diabetes. Encouraging initiatives, policies, and laws that promote equity for all people living with diabetes. So if you haven't done so, go to enddiabetesstigma.org and take the pledge. We count on you. It has already been translated to 12 languages. And at the international global community, we're working on this hard. So the international consensus, what's that? And how is it tackling diabetes stigma? Well, you can download here using this QR code. It's a download that is completely free. And the consensus statement has been published in the prestigious Lancet Diabetes and Endocrinology journal. The first step was to engage with an expert panel, a panel that is composed by 51 people from 18 countries, 6 low and middle-income countries, from all 7 IDF regions. 33% of them with lived experience, and 37% with a family member living with diabetes. Others with professional expertise in the field of diabetes, coming from research, clinical, or advocacy. The methodology used to generate evidence was a triple-round Delphi methodology. And there are some statements that reached unanimous agreement. Among them, we can find these ones. Large cross-sectional studies suggest up to 4 in 5 adults with type 1 diabetes or type 2 diabetes experience diabetes stigma. That's a lot, like 4 out of 5. Wow, it's almost everybody. And on average, 1 in 5 has experienced discrimination due to diabetes, unanimously agreed by everyone, the 51 experts. So, in order to know the real definition of stigma and discrimination, you can see the slides. Diabetes stigma is experienced by 65% to 99% of teenagers. We know that when we are teenagers, we are especially delicate and sensitive regarding being different. Living with diabetes is certainly being different. And stigma does not help our teenagers and adolescents. So it's time that we help them. 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% 60% This is another statement. People with diabetes experience diabetes stigma from numerous sources. Healthcare professionals, health organizations, general public, even family or friends. It's unbelievable, but many times stigma is well intended. Because who hasn't heard the famous words, "Are you sure that you can eat that?" For example, this statement also had a grade of unanimity. Everybody agreed. There is an inaccurate, overly simplistic societal view that people with diabetes are to blame for their condition and its complications. Unanimous agreement as well. It's really tough to think that a person living with diabetes has caused himself or herself diabetes. It's quite emotionally challenging, to say the least. Even more if we are talking about complications that are still a taboo and can be due to bad glucose management, of course, that's possible, but also because there are many other factors, for example, socioeconomical conditions, mental health issues, issues of access. Not everybody can access all the things that they need to live. And in order to have a good glucose management when you live with diabetes, you need so many things at the same time. You need access to doctors, you need family support, you need a network of friends, you need your psychologist, you need your doctor, you need a lot of money, you need your emotions to be stable. How can your emotions be stable when you have just been diagnosed with diabetes? When you have to go through life and diabetes at the same time. Sometimes it's a lot and all comes together. Some healthcare professionals contribute to diabetes stigma by blaming, judging, and mistrusting people with diabetes. There was a very high grade of agreement. And for many of us, going to the doctor's appointment, sometimes it's challenging to, how are they going to treat you? Are they going to assume, what happened here? There's a hypo on the day 24th at 3 a.m. What happened? Oh, I don't remember. So it's important that healthcare professionals start addressing the people that they are dealing with and not just seeing a disease, but see a person beyond the disease. That will surely lead to better outcomes. People with diabetes who anticipate, experience, or internalize diabetes stigma are more likely to hide their condition from others. For example, delaying or skipping essential medication, taking and glucose monitoring in public with implications for their health. Unanimity as well. Of course. Not long ago, injecting in public was seen as a taboo, as something that was not that normalized as it might be today. I think the movement of the global diabetes community and everybody being more open about living with diabetes is changing things. It's improving things somehow. But it was not always like that. When I was diagnosed 33 years ago, I thought I was the only girl living with diabetes in the world, and I think that that has happened to all of us people living with diabetes, that we were the only ones. Then things changed, and they got better. So that's why peer support and being part of the community, being open about our diabetes and the psychosocial challenges that come with this diabetes is so important. Stigma was also associated with a lower sense of well-being and less self-efficacy for diabetes management. So there's no good that comes with stigma at all. In fact, it impacts our health outcomes. It worsens our numbers. It's an emotional thing that in the end affects our physical health. People with diabetes who experience diabetes stigma in healthcare settings are more likely to have higher HbA1c and or severe hypoglycemia, experience lower quality healthcare and consultations, disengage from healthcare, and experience delayed access to treatments, technologies, and specialist care. Unanimous again. So if we want, as healthcare professionals, to have the best results for our people living with diabetes, it is essential that they are stigma-free, and that way they will be more open to receive treatment, to receive technology. While emotional reactions are similar in, for example, teenagers, healthcare professionals, and parents, behavioral responses differ. Healthcare professionals become more disease-focused as opposed to patient-focused, distancing themselves from patients and their parents. We are treating people, not just diseases. Parents become angry, nagged, threatened, and often blamed and shamed because of the management. Stigma does not benefit anyone, that's so clear. While teens living with type 1 diabetes tend to be rebel and become non-adherent, well, that non-adherent is not the best word because language matters, yeah? But they don't follow the treatment or they don't follow up with the tasks that they need to maintain, to manage their diabetes. Some people with diabetes experience unfair treatment and or discrimination due to diabetes in relation to marriage, childbirth, healthcare, education, employment, insurance, and licensing. For example, driving a vehicle. Well, most of people agreed here too, most of the experts. But this is essential, very important in countries like India, low middle income countries, where, for example, the culture of marriage is so important. And there are even arranged marriages. We have people in the Asian region who were told that they will never be able to marry because they live with diabetes. That's so cruel. Also the challenges when women want to have children and they're questioned due to living with diabetes. So people with diabetes tell us, and quantitative data shows that diabetes stigma and discrimination has multidimensional impacts on the health of people living with diabetes. Worse emotional and physical health, less optimal beliefs or attitudes about diabetes and self-care, non-disclosure and social withdrawal, as well as lower access to quality care. There is also data to suggest that diabetes stigma is associated with lower public and financial support for diabetes care and research. So, the synthesis of recommendations from the consensus are specific and provide reference to actions for organizations, health professionals, settings and bodies, media, government, as well as researchers and research institutions. Importantly, the recommendations promote collective action that is grounded in meaningful involvement of people living with diabetes. We have to tackle diabetes stigma, but with the community. Let's change the narrative. Diabetes looks like me. Do you remember that campaign? It was a campaign of JDRF, a Breakthrough T1D, that was formerly known as JDRF. And we would upload pictures of ourselves saying, diabetes looks like me. Well, that was a very good way to change the narrative and to make people see that diabetes can look like you, like a model, and have a more positive vision that helps and empowers people. Avoiding stigmatizing imaginary, avoiding fear-based tactics. Let's change the narrative and take language into account. Language certainly matters. Language matters when communicating about diabetes. So, key takeaways. Diabetes stigma is real, prevalent, and detrimental. The consensus and the pledge seek to kickstart localized action, and everyone can be part of the solution. All of you can be part of the solution. What's next? Well, very quickly, and I have left this for the end because it's so exciting. We will be holding our first End Diabetes Stigma Global Summit in India, coming very soon. So if you are interested in attending or being part of this event, I invite you to send expressions of interest in diabetesstigma.org/Global Summit 2025. Please express your interest before April the 17th. It's coming very soon. Do it very soon because we look forward to seeing you in India, addressing this situation worldwide. And of course, as lived experience lead of psychosocial aspects of diabetes study group, I now want to recruit you by showing you the amazing meetings that we are going to have very soon. One in Cluj in Romania next month, and next year we will be traveling to Australia. So I invite you all to join us and tackle this aspect of diabetes that is as important as the physical one, the emotional and psychosocial aspect of diabetes. Thank you so much.
Ladies and gentlemen, my co-chair Louise and I were informed that Professor Bernard Kelly actually pre-recorded her lecture. So what we'll do next is to listen to her presentation, and if there is some time left, we'll have questions and answers.
I'm guessing we have some technical issues, and there are supposed to be sound. Yes, yeah, okay. Do we have time to take a question while we fix this? Yeah, then we have gotten a few questions on Slido, so we'll do one of those while we try and get the technical things solved. So can I ask Nasser to come up on stage, because we have a few questions for you. Someone has written, thank you for a very interesting presentation. Not every context will have a psychologist able to provide services such as you do. How can we organize psychological support in such a setting? Do you have any comment to that?
Thank you for the question. So when I talk about psychological support, I think that's one of the things that makes the question of whether every person living with diabetes should see a therapist. I think making it seem like psychologists are the only way for us to tackle mental health of people living with diabetes is a problematic state to start with. And I think it's within the conceptualization of mental health and how we look at mental health today. If you have mental health, you have difficulties, the only way you deal with it is you have to go to therapy, deal with it on your own, and that becomes, and I thank my colleagues for their presentation, and a lot of the work I do is community mobilization. And most of it, I recently became a psychologist, and a lot of the individuals I work with have never been to therapy. And I think a lot of community mobilization, a lot of work on stigma, a lot of work on access, right? I think are all ways to tackle mental health. And psychologists are one way to do it. But I think mental health is so much more multifaceted, multidimensional than that. And I hope I answered.
No, no. And another question that's sort of into the same subject, so I'll read that straight away as well. Should diabetes education and endocrinology courses be lengthened to include psychology or counseling subjects? Do you have any thoughts on
I think
that?
I'd have a similar response to that.
Yeah.
Well,
Yeah.
again, I think making it seem like diabetes exists in isolation, and the only way to tackle diabetes and mental health is through a psychologist. So the main way to do it, I think, because again, here we're talking about access, we're talking about funding. So it's pragmatic, and it's also kind of neglects all the other factors that exist simultaneously.
Thank you. No technical solution yet? No? Then we'll continue with a few more Slido questions, because you asked a lot of questions. Thank you for that. Amanda, could you join on the stage as well? What is your vision for how our healthcare systems can better support people's fear of complications and daily insulin administration?
Good question. I know that you have to educate people living with diabetes about the risk to get complications, but it's the thing is how you talk with the person living with diabetes about these risks, because I feel like especially doctors, they are very like strict and something like that. So they just, oh, don't do this because you will have a heart attack in the future and things. And they have to understand the burden of getting that information and the fear it can become. So I think you have to educate them to have a little more soft voice, if that's can describe how I think.
Can I weigh in a bit? As a physician myself, and who was an eye-opener. No. Eye-opener when I was doing my PhD in health psychology. A lot of it was qualitative work and collaborating with psychologists. And I was interested in diabetic neuropathy and complications. And what we learned that, for example, fear or worry about losing your leg, fear about pain because you don't know the origins. A lot of it underlying those fears are misconceptions. So first of all, what we did, we uncovered those misconceptions. For example, people are fearful of amputation because they think that is due to vascular blood supply, and it's inevitable that you'll end up with amputation. Whereas when you explain that it's actually controllable condition, it's usually neuropathy and can be controlled. So you have to provide those people with clear picture what is going on and provide clear action plan. That sort of diffuses those fears. Same with fear of falling. People feel like the stigma, again, stigmatized. When you explain that it's not due to your age, that is a complication that can be controlled, there are ways of improving balance. So you have always discuss, see what underlies those fears, and provide with clear action plan, because just arousing fear without saying what to do about it is meaningless or is counterproductive.
Yeah, absolutely, and sometimes it's, in Sweden at least, I think it's so in many countries, but you have child care and then you have adult care. And at child care, everything is like fluffy clouds. Everything. Oh, you get this insulin pump in Sweden. You get this glucose monitor. Here are stickers. Everything is good with diabetes. And then when you turn 18 in Sweden, you move over to the adult care, and they like, oh, we have to check your feet. We have to check your eyes. Everything. Yeah. So it's have to meet the patient in their age and who the person is.
Thank you. I think now the technical issues is solved. So yes, we'll try again and see if we can listen to Professor Bernard Kelly.
Hi, I'm Professor Catherine Barnard-Kelly, and I am thrilled to be able to share with you some insights around diabetes technology and its impact on mental health. Here are my disclosures. And as you can see in the ADA and the EASD guidelines on precision therapeutics in diabetes, technologies are increasingly integral into those pathways. But it's really important that physical and mental health are considered equally, because if they are not, one will surely suffer as a consequence of the other. And before we go on, it's really important to remember the elephant in the room, in that access is not equal for everybody. And there are significant differences in people's ability to access technologies such as insulin pumps, CGM systems, closed loop systems. And those inequalities are driving and further reinforcing inequalities in outcomes for people with diabetes. A contributing factor to those inequalities remains healthcare provider inherent bias. This is not an overt thing. However, it's really important that we think of our own biases in how we engage with our patients, because it does have a direct bearing on whether those patients can access devices that can really improve their outcomes in terms of glycemia and quality of life. And you can see here, ethnicity and deprivation year on year shows these inequalities are not getting any better. So when we think about technology and technology onboarding, it's really important to think about a few key things. It's not who the patient is, it's where the patient is at. Every patient can benefit from diabetes technologies, but maybe not today. Maybe another time. Maybe there's so much going on currently that a technology might increase burden rather than alleviate and give benefit. Because diabetes technologies do come with benefits and burdens, and it's really important to understand the trade-offs that people make when they engage with these systems. These effects are both physical and mental. And you can measure physical health, but you can only understand mental health by asking the patient appropriate questions. So technology contributes an enormous amount, and it's been very exciting over recent years to see the developments in diabetes and how people are benefiting from these amazing advancements in technological development. We have precision, we have greater accuracy, reliability. The remote facilities on some devices can really help families in particular to feel much more connected and supportive of each other around disease management. There are clear optimal glycemia benefits, and many people report improved quality of life as a consequence. There are cost efficiencies, and often they can enable access to healthcare which may otherwise be beyond reach in terms of some of the telemedicine advances that we've seen, particularly during the COVID years. But when you think about technologies and you think about health, what does that mean to a person's lived experience? Because the World Health Organization has been saying since its opening charter more than 75 years ago that health is not simply the absence of disease, it is the presence of physical, mental, and social well-being. So when you think about your patients and you think about the technologies available to them, for whom will get the most benefit, and in what way will those benefits be realized? How do we know that? Thinking back to the bias comment that I made earlier, how can we demonstrate it for everybody? How do we evaluate it for everybody? And how do we use those results to improve the application of these devices and technologies? They're really important questions when you think about the scarce resource that we have in healthcare and how we can best meet our patients' needs by introducing the technologies that they can really benefit from. So when we think about technology, there are some fairly obvious things that impact a person's ability to engage. So health literacy, numeracy skills, for example, can play a big role. And it's important to remember access to things like smartphones, for example, continues to be very unequal. The person's views on visibility of disease state are important because diabetes devices increase visibility. What are the options that are actually available? What are the expected benefits in terms of glycemia, social functioning, and quality of life? And how much effort is needed to realize those benefits? Because devices come with burdens as well as benefits. What are we hoping will be the impact on diabetes self-management behaviors? And have we considered any impact on significant others and carers? For example, the share facility or alarms, because alarms can be beneficial, but they can also be very intrusive. And it's important to think about these things when we're considering technology and the impact it might have on an individual's mental health. So, benefits and barriers for whom? People have expectations and they also have irritations around devices. So, expectations are often very, very high, as you can see here on the left. And irritations can very, very quickly turn into discontinuation of use of devices. So if you have a poor user experience, for example, if it's too complicated, if you don't feel that it meets your personalized needs, alarms, intrusive or helpful, and visibility. These are things that make people stop using devices. So it's really, really important that we understand people's expectations, before we onboard a technology that may not be the best fit. And there are hopes and fears around device use, technology use. Data security breach is a big worry for people. Privacy. Will it give me the right advice? Is the information, is the data that I am receiving accurate? Does it meet my needs? Because what people want is for the technology to benefit their glycemia and quality of life outcomes at minimal burden so that you can live a full and happy life despite the fact that your pancreas doesn't work. And you can look at some of these issues kind of like a seesaw. So think about daily glycemia patterns and trends. For some people, there is improved awareness of impact of food and behaviors, and you can see very quickly where the trends are going and the arrows on your continuous glucose monitoring screen. But for others, the increased anxiety, feelings of hopelessness and despair can really be challenging when engaging with these systems. Alarms, as I've mentioned, they can be extremely valuable in alerting the user to action that may be required, and it helps you be responsive and confident that you can manage in the event of hypoglycemia, for example. But they can be very socially intrusive, and it can draw unwanted attention where you might not have expected it. The share facility can be really, really valuable for families when you're trying to keep your child safe at school, for example. But it can also make you feel more judged. It can make someone feel like your partner knows too much about your glucose readings. Maybe they can't respond. Maybe they feel helpless. Maybe they don't know what to do for the best. So it's really important to have conversations around the share facility before you start using it about who is expected to do what, how will that work, when are they allowed to contact you, when should they just leave you be. Frequency of attention. We know that people look at their continuous glucose monitoring data to different degrees. Some people will barely look at it. They'll check it in the morning when they wake up. They'll barely look at it all day. As long as the alarm doesn't go off, everything's fine. Other people will be looking at their data 20, 30, 40 times a day. And it can create a pressure to serve diabetes and be ultra vigilant and ultra responsive when actually it's already good enough. Perfection is the enemy of the good. So it's important to manage how much intrusion the device is going to have in a person's everyday life. How much headspace, how much mental energy is going to be required to manage that system. Similarly with trend arrows, it's important to understand how long you have to wait after a meal before you can react. And seeing the trend arrows shooting up or shooting down can be very worrying for people. This may seem like a really obvious one, but understanding why do you want it? What is it going to help you to achieve in terms of your lived experience and diabetes management? Is it going to be something that is super helpful, that can free up time and headspace to devote to other very important things like work and family and relationships and happiness? Or is it something that is something else you have to do to manage your diabetes? Because nobody needs another job when managing their diabetes. So I'm going to direct you to diabeteswise.org, which is Professor Corey Hood's website, and it's absolutely brilliant. I would urge you, if you're looking for a new technology yourself, or you're looking to support your patients with choosing the right technology, this website is an absolute wealth of information from both the glycemia and psychosocial perspectives of device use. So it's absolutely brilliant. Diabeteswise.org, definitely worth a look. If you are looking for something that is more helpful within a routine clinic environment, then the Spotlight AQ platform can really help patients and clinicians together to work on what device may or may not be the best fit for them. So it works, it gives a glycemia 360-degree view of the patient from a psychosocial and glycemia perspective. It helps people to understand their barriers and facilitators to optimal engagement, and then it helps clinicians to work with patients to better understand what is the best outcome. So there are two parallel themes. Patient fills in a survey about lived experience, it's AI generated. Providers see the results immediately, and they have the resources to help signpost the patient to safe evidence-based support, whether that be from a physical, mental, or social well-being. And it can be really useful to have that 360-degree perspective when thinking about device use and onboarding. But with all of these things, the psychosocial aspects of disease management have an enormous research base. It's very, very clear that if you want optimal glycemia outcomes, you also need to address mental health challenges and mental health support, because you have to have both. Physical and mental health go hand in hand, side by side. And as I said earlier, if you only focus on glycemia, then any diabetes technology will fall short in supporting somebody living with diabetes. Thank you very, very much for listening. I'm sorry I couldn't be there in person. Please do reach out to me. You have my email address there. If you have any questions or any comments, you are very welcome to email me and reach out. Thank you very much.
Okay, with that, we are exactly on time. It just turned 10 o'clock. So I'm afraid we don't have time to do more questions here, although there are a lot of questions that have showed up on the Slido app. So I kindly ask if the speakers would like to maybe remain outside for a little bit, and if you have more questions, please approach them with that. Thank you very much for joining this session.
Thank you, everybody.